I got to do this a little quick. This is like 70 or 80 slides, so my New York talk. This is the last part of chapter 6 on artery occlusion. It's not too hard, but I did most of it's a book, but then I added some more stuff in some cases. So we've been doing retinal vascular disease. We did everything on there. We did hypertension, macular aneurysm, vein occlusion last time, and I think carotid occlusive disease is in this one, and this time we're going to do arterial occlusive disease. And then next time, I'm not sure what we're doing next month. I'll have to email you. So first of all, we talk about ocular ischemic syndrome. That's gonna be hard. It's from chronic severe hypotension from the carotid, which you guys said you tested for. It's 7.5 cases per million, so it's not common. So you're not going to see this often, as opposed to vein occlusion, which is about 1 per 1,000. It's gradual vision loss, aching pain, and then what you'll see is NVI, and a lot of people have uveitis. So, and often the pressure's low. So you have NVI with low pressure. Sometimes you get retinal hemorrhages, and what we tend to look for is temporal hemorrhages or hemorrhages kind of on the median raphe, where the vessels come together on the side, because those are relatively ischemic. And then you can do an FA, or like I said, you can push on the eye. You look in the eye and push on it and see if it occludes easily. This is the thing that, a lot of times this is something when you're trying, am I in there? Looks like it's pointing a different way. A lot of times it'll come to me later. I'll be seeing somebody for a couple months and the eye's just not right. And then I'll think, oh my gosh, it might be ocular ischemic syndrome. This was a 75-year-old guy I saw some years ago. He had laryngeal cancer, and they radiated him. And then he started to get very narrow carotids. Then he was told he was totally occluded, but he had a patent vertebral, and he had mitral valves that weren't that good. He was sent for macular puckers. His vision was 20/60 and 2200. Excuse me, and the maculas looked pretty good. There's a little bit of an artifact there. And this was at 32 seconds. He's got delayed filling. Well, they're not terrible. And then what you can see here is the foveolae vascular zone doesn't look right in each eye. And then if you look temporally, they're the funny looking vessels temporally. So that's kind of an ocular ischemic syndrome. It's usually atherosclerosis. It can be giant cell arteritis, and most people lose vision. And you can fix the carotid, and you can do PRP or anti-VEGFs. My experience is those eyes are just very difficult to fix. Sometimes they're vitreous hemorrhages. You'll get an unexplained vitreous hemorrhage. So then that's separate. So then these are all arterial occlusive diseases. So we're going to do Cottonwool spots, branch artery occlusions, ciliary retinal artery occlusions. I don't know why, but paracentral acute middle maculopathy is in this, and then central artery and ophthalmic artery, and try to make it interesting. So Cottonwool spots, like we've talked about before, there's a compromise of the peripapillary capillary net, and they're small, they fade in 5 to 7 weeks, and even one Cottonwool spot should be worked up. I have an internal medicine doctor I saw recently. I've been treating her for retinal tears, and she had a Cottonwool spot on one of the exams. So this is the radial peripapillary capillary network, and that tends to be where Cottonwool spots are. The capillaries are a little longer than average, and they don't anastomose, so that's why you tend to get them there. And the radial peripapillary capillary network is there in proportion to the size of the nerve fiber layer. Do you guys remember the other capillary? Now that we have the OCTAs, there's the other capillary networks. There's the superficial vascular plexus and the deep vascular plexus. If you look at your OCTA, it says SVP, DVP, and each of them, I believe, splits. Actually, we have them some. That would be coming up later. This was an HIV positive patient. I saw that's the most common cause of Cottonwool spot. She was symptomatic. She noticed spots in her vision, which is interesting, because often Cottonwool spot patients don't see spots. And she had all these Cottonwool spots up there. And she did not have CMV retinitis. I mean, that was always stressful, trying to differentiate CMV retinitis from this stuff. But so this is Cottonwool spots, which is a lot. Really, HIV, it used to be lupus was the one when I was younger. So when you had a Cottonwool spot and you looked at if you look at a review article, an old review article, you'll find most of them they end up diagnosed with lupus. If you look at a newer article, most of them are HIV. And that's if they don't have, hypertension. You'll see them with other diseases, but that's more for isolated Cottonwool spots. You'll see them in vein occlusion, you'll see them in hypertensive, you'll see them in diabetics, but that person has hypertension, diabetics, or vein occlusion because you can see the vein occlusion. But it's the people that are the sickle diseases. But you'll see some people with just cotton wool spots. The other thing is an older person with a cotton wool spot who's a little bit off, you got to raise your threshold for giant cell arteritis, because I've seen people present with that. So if you get someone who has like a branch artery occlusion and then there's a cotton wool spot somewhere, that's like very unnerving for a giant cell arteritis. And what cotton wool spots are is occlusions of the very small capillary, so it's not really embolic, which is where I'm not sure why it's in this grouping, but we think they're immunocomplexes or cytotoxic molecules damage the vessels, or it ends up with a little infarction. So immune complexes are small enough to get into the capillaries and include the little lumps of proteins. Branch ret, so any questions about cotton wool spots?
Yeah, so if I saw a little vein occlusion with the cotton wool spot on the other side, I think, oh, this is just going to turn into a full central retinal artery occlusion.
Yeah, if it doesn't turn to a central vein, then you got to get nervous. There's something else.
And so then what would you do for a workup?
If it was a small vein occlusion, a cotton wool spot down here, I would probably check their blood pressure myself.
Yeah.
And then I would probably talk about getting an ANA. And I ask them now about getting HIV. It's a little weird.
So ANA and HIV is what you...
Yeah,
Okay.
because the HIV test, people don't really want to get that.
Okay.
You know, especially when they're in there. With
Well, now in the hospital we can do it. We don't have to
Oh, you
get
don't have to
permission. They just, if they refuse it, we can't do it. Otherwise, we can do it, right?
Okay, because I have to order it. So I did. I had somebody. I said I had a cotton wool spot last week, and I said I really got to do some testing. And I said, "Is it okay to taste it?" He goes, "I don't need that." I don't. Okay. Ranch. You know, it's funny because you don't know. Like, there's that whole thing of all the people you know and all the people they know. They used to do these old Saturday Night Live skits with all of them sitting around the bed, like while you're sitting there romantic, and all your previous lovers and his previous lovers are there like watching you. It's kind of funny. Branch retinal artery occlusions are almost always embolic. There's 3 different plaques. They're usually cholesterol, platelets, and calcific. It's interesting, Dr. Reichenbaum had a patient whose last name was Hollenhorst. And their uncle was one of their uncles was the person who named the Hollenhorst plaque. It's a funny name. I just saw the patient post-op because they had a macular pucker or something. It'd be interesting if they had a Hollenhorst plaque. But there was a guy that I gotta go. There's the guy who invented the shopping cart. Died about a decade ago, and everybody was making jokes about the hearse like pulling to the side when they were trying to, because shopping carts you can never steer. Okay. So anyway, this is like a little side. So anyway, then someone there's an old paper on different types of emboli I pulled so most of them are cholesterol. So they tend to be mostly cholesterol, some fibrin, some calcific. This is a 69-year-old person with sudden vision loss a day ago, came in with a branch artery occlusion. They're usually not subtle. The retina gets all white. This one's got some hemorrhage too, which is not common. And the retina will be thickened when you do the OCT. It's an intraretinal problem, and it usually is all layers, although I'll show you another case where it's just the middle retina that whitened, and then you get occlusion this is a different patient with occlusion on the fluorescein. And then this is one showing a Hollenhorst plaque, so you can see the plaque right up there in the vessel. So those are kind of branch artery occlusion. So the thing is, for branch artery occlusion, do you urgently refer them to the emergency room, which I believe is part of the textbook, and there was an editorial on AJO a while ago. So anybody comes in with a branch artery occlusion, I always ask for focal neurological events, weakness, slurred speech, face not looking right, prior or concurrent TIAs. And there was a study done by this group in Korea where they had 33 patients they collected over 7 years. It's a big center, they publish a lot. And they did a retrospective review of all their artery occlusions and pulled the ones with MRIs. And they found that 8 of those 33 had an acute ischemic stroke, and 3 didn't have any symptoms. So based on that, the editorial with the paper said that you should refer patients with branch retinal artery occlusions for workup as though it were an acute stroke. I can tell you in practice I don't do that, and I don't think this paper justifies that for a couple reasons, and I wrote a letter to the editor saying all this. One is that if you have over 33 years, in a large eye center, you probably see hundreds and hundreds of branch artery occlusion. So if you pick up a couple where someone did neuroimaging, I think even the ones where the chart doesn't say it, they probably had it for a reason. So if someone's got a branch artery occlusion, in my case, I tell them they need to get a stroke workup, and I usually send a letter to the doc and say you should call your doctor within a couple of days. But for the purpose of boards, if you can't, you can. And the other thing is, in medicine, you never are going to get faulted for being too thorough. So no one's going to sue you for sending people to the ER with a branch artery occlusion. But I don't send it. I send a letter to the medical doctor.
Central artery.
We'll get to that, yeah.
All right.
Central. So there was this editorial, acute retinal arterial ischemic, an emergency often ignored. TIAs are an emergency. So if someone's got a recurrent TIA, 10 to 15% of them have a stroke within 90 days. Half of those are the first 2 days. So when someone comes into me, which is once a week, someone will come in with transient vision loss because they have vision loss. So they go to somebody, they end up at me. And when you talk, the eye looks normal. So someone has transient vision loss, and sometimes they're one-eyed. It's all really weird because sometimes they'll think it's just one eye losing vision, but it's transient vision loss. And if someone's got recurrent transient vision loss, and it's about the right time, which is 5 to 7 minutes, then I tell them they need to, call their medical. I'll say this letter's going right to your medical doctor when you get home. I want you to call them, or if I'm really nervous, I'll send them over. And then TIA and strokes are treated like TIA. The relationships between TIA and strokes are considered like the relationship between angina and an MI. So it's supposed to be taken seriously. So for branch artery occlusion, I think they need to be worked up for strokes. And then there's all these rare causes. Like I was saying, if you just try to remember them in general, anything that can shoot emboli up can give you branch artery occlusion. So the fat emboli or the myxomas, and then anything that can give you a retinitis can give you branch artery occlusion. Prognosis is good. So most of the patients have a good vision. The blind spot usually shrinks, and so 25% of I was looking for data on recurrence of embolic branch artery occlusion. I couldn't find it, but I've seen it written some places. So when people see you, the things they want to know is, am I going to get better? Is it going to happen again? Those are the two questions I get most of the time. So usually branch artery occlusions, they usually do get better. Your vision usually comes back, and then the chance of it happening again, I think, is about 10%. There's good data on stroke, so 25% of patients who have a stroke have a second stroke. So I think for branch artery occlusions, maybe 10%. Also, if you want to get anatomic with the patients, you can explain to them the first branch off your heart is your neck, and the first branch off your neck is your eye. So I believe the ophthalmic artery is the first. Okay, good. Used to be true. And then there are some syndromes. So there's recurrent branch artery occlusion syndromes. There's two. There's idiopathic recurrent branch artery occlusion, which is sort of linked to migraine and probably inflammatory. And then there's Susac syndrome, which you probably don't need to know, but he is a neuro-ophthalmologist in Winter Haven who happened to have named a syndrome, so he's got a syndrome name for it, which is kind of interesting. They get tinnitus, they get recurrent artery occlusions. There's 3 types, and they have a MRI that shows these things in the corpus callosum. I can't say I've had any. So I've had 2 patients with definitely recurrent syndromic artery occlusion. That one I thought had Susac, but they never quite got diagnosed.
Don't they get something in the, like a gas block, they call it? Don Gas describes something in them.
The recurrent artery occlusion?
In the Susacs.
Oh gosh, maybe. I know Gas was interested in a recurrent branch artery. We used to talk, but I don't know about this. They can, but the Susacs are supposed to be on. They're supposed to be on CellCept and stuff. They should be on anti-inflammatories and biologics. So we did Cottonwool spots branch artery occlusion, and now cilioretinal artery occlusion. So cilioretinal, that's why. So that patient has cilioretinal artery. It's about 18 to 32% of eyes. You see them most in central vein occlusion. So if someone asks you, they could ask that. Cilioretinal artery occlusions commonly are concomitant with central vein occlusion. Also, they can see in giant cell arteritis because of the distribution. This is a 69-year-old patient. She had a cardiac catheterization. And right after the catheterization, she felt funny, and then when she could see, she had a blind spot, and you can see this is the cilioretinal artery right there. It's occluded. Excuse me, and then the FA shows it's occluded. This was interesting because I'm finding this more with OCTs on people with ischemia. Sometimes it seems to spare the inner retina. So in this case, it was just sort of a middle retina ischemia. I think that's probably got some interesting meaning. Paracentral acute middle maculopathy is, I think, totally separate from all of these things, but it's lumped together in the textbook under artery occlusions. So paracentral acute maculopathy is a fairly obscure diagnosis where you get the deep macular capillary plexus. So there's that superficial vascular plexus and the deep vascular plexus. They get an occlusion there. And people are saying, I guess they say, actually I guess superficial. So type 1 is superficial capillary plexus, type 2 is deep capillary plexus. Just to jog your memory, there's two capillary networks. So we talked about the peripapillary radial nerve fiber layer, and these are the other two. So there's the superficial, which is here, that straddles the ganglion cells, and then there's the deep, which is here, which straddles the internuclear. You can just think, there's like you can see there's a lot going on in the nuclei, so they need more oxygen. So
is there some weird association with PAM in some other entity?
you can get PAM in a bunch of things. We reported, actually I have a case here. This was a 55-year-old woman who I still see, who came to me with a sudden blind spot in her eye. And she had this white spot here, which is very hard to see on the color photo. And she also had vasculitis. So she has leakage from her vessel. She's got diffuse vasculitis, very subtle spots on the ICG. I have to say, I sent her for, I think this was the one. Because of the uveitis, I sent her for a workup, and I think I accidentally wrote HLA-A29 because I really wanted to check a B27. Sometimes I'm busy and I write A29, and it came back positive, and she was birdshot. So she had, what's his name? Reported this. Where's his name?
Andrew Carey.
Yeah, Andrew Carey did this. And then what you'll see is thinning later, where the paracentral acute middle maculopathy was. So so you'll see it. You can see it, and it's been associated with a bunch of stuff. The thing you see it most commonly with, I think, is central vein occlusion. So if you get central vein occlusion, a lot of them will have a bunch of PAM lesions. My experience is those people don't do well. Those seem to be especially ischemic. They're doing pretty well. And then central artery occlusion. That's the big one. So sudden, severe, painless vision loss, cherry red spot, usually their vision's poor, 2400, although some of them have 20/40 or better. Most of those are cilioretinal, but sometimes you can have good vision. That's the other thing I was to say with the branch artery occlusions. I've seen sometimes branch artery occlusions will be in a weird branch, and I've had patients with nasal, I was going to try to bring a nasal BRAO, which can be very confusing, because usually they'll look over there and people will see a visual field defect and get all sorts of crazy about it. So it is sometimes important to look at the other circulation away from the macula. And it's very central artery occlusion are either emboli or GCA. And they're at a high risk of central artery occlusions you could send to the ER, I think. And this is a typical central artery occlusion with cilioretinal sparing. This, unfortunately, cilioretinal artery didn't quite get to the fovea. So, and then the OCT. So what you expect is swelling initially, and then it goes to atrophy.
Is it cherry red just because of the pallor in the posterior pole? Is that why it looks cherry red?
The retina is transparent, which is remarkable. So your retinal, your receptors are on the back. Mm-hmm. So your inner retina is transparent. And what happens in this disease, which is true of retinitis, is the retina loses its transparency. So then what you get is your ganglion cells swell, but in the fovea, there's no ganglion cells. So, and also the other thing is the retina, the artery provides circulation to, do you know how much of the retina it provides? Is it 1/3, 2/3? It's 1/3. So the central artery provides circulation to the inner 1/3 of the retina, which is, I guess, broadly true. And your choroid provides circulation to the outer retina. And so in the fovea, really the choroid's adequate to perfuse. And unfortunately, it's like where I live in St. Pete, we always look when global warming hits. I'm at 14 feet, so I think we'll be okay in our house, but we won't be able to get to it because everything around us will be flooded. So it's the same thing here, because the fovea, those photoreceptors are fine, but everything around it is dead.
Yeah, helicopter.
Yeah, or just build up the roads.
No.
I think it's going to be a lot of economic problems.
Tender.
So central artery. Oh, the other thing we had, I always talk about this case. We never wrote it up. It's probably 20 years ago. But there was an interesting case we had of a patient with severe glaucoma who had a clear central artery occlusion, which you could see angiographically. This was before OCT. And they didn't lose vision. And I think it was because the nerve fiber was so shot that the choroid was adequate to perfuse the whole retina. And they actually did really well. It was a cool case. So theoretically, you could, if you had an atrophic retina. There was a study done in Europe, a central retinal artery thrombolysis. They did selective, this was heroic. They got patients within 20 hours, 82 patients, and they did selective TPA into the ophthalmic artery to look to see if that would help, and it didn't. So it's nice, so you don't have to worry about treating them, because if that had been positive, it would have been very anxious what to do with the patients, although it would have been nice to help. But the other thing is their control group, they did a lot to in this study. So their control group, they had isovolemic hemodilution, which I've never done or heard of actually. And they also did ocular massage, and they did with a contact lens, and they did a beta blocker, and they did intravenous acetazolamide. I guess because they were in the hospital, so why not? So those were all their control groups. So there is a lot you can do to someone with a central. They didn't do AC paracentesis, which is actually the one thing I do. So if I get someone with an acute central artery, I'll do a paracentesis, but I don't hemodilute them, and I don't do any of the other stuff.
Have you ever done systemic TPA like you do for a normal stroke? Say someone comes in.
Well, presumably this wouldn't work because selective didn't work. I think
that's 20 hours later. Then.
Yeah, systemic. There was this. My recollection is there was a systemic TPA study started for, I believe, branch artery or branch vein occlusion, where they were trying to treat people within a short time, and I think it was the third or fourth patient that I think died of a hemorrhagic stroke.
Yeah.
And it was stopped. So and that probably never got published because it was before the gov.on. Is that still in course? I think it should be.
Because for a stroke, you're doing it within
23.
90 minutes.
Yeah, for a stroke, and the other thing is if you have a stroke, you can say you have a stroke. So the thought was the eye's not as important. Although you wonder with the central artery. The central arteries are a big deal. This shows how they did the microcatheter and how they got it in. And the thing was they had 60% of their patients improve, which is a lot. But actually, it wasn't that much improvement. So the final visual acuity was only better than 2,215% of the patients. This paper, it was all logmar. I actually had to calculate all this stuff for this lecture. I hate when people put logmar visions. But only 15% were 2,200 or better. So central, this was a 74-year-old guy I saw recently with sudden vision loss, and this was his retina. This is an interesting picture because this almost looks like an ophthalmic artery occlusion to me because there's really not much of a cherry red spot. But really, if you have an ophthalmic artery occlusion, you should be NLP or bare LP, and he was hand motion. So I think this is a central artery occlusion just without much of a cherry red spot. I think maybe it was a blonde fundus, who knows. And if you look at the OCT, it's all swelled up. I don't think we've quite got the center of the fovea there. And then the circulation on the fluorescein, that's at 28 seconds, and this is 44 seconds. So you can see it's just not perfused. That's a minute. This man, I believe I just did, he got neovascularization. I did PRP, and then he went to no lid perception. I just saw him yesterday.
So it is perfusing there, but the thought is that it's obviously it's delayed, but the thought is that you have no. So you think this is what it looked like at the time of the occlusion?
Mm-hmm.
If you did that.
I mean, actually, if you were good with your anatomy, this is probably not perfusing through the central artery. The central artery is probably total occluded. There are some anastomoses around the nerve. And it takes me, I'm going to get lost in this, but there is a way for the blood to get to the central artery through the capillary plex. Sort of goes through the.
Yeah, it's like the.
Sit and talk about it
the
over here. You got to go through the artery. You got anastomose through. You go through the artery to the vein, and then it can the veins will anastomose, and then it can get into the other veins, and then kind of go backwards into the capillary, into the artery, and then back out into the circulation. I don't think it's coming from the central. I think it's coming around the blockage through a bunch of. I think it's coming through the choroid and back into and then back around and then up. It might, I don't think it's getting through. I think it's a total occlusion in this patient. And the other thing is if you're going to do an AC tap, I get a fluorescein first because most of them are reperfused. It's actually relatively uncommon to find one that's not, that's like this.
You put a time factor on when you might not do an AC tap?
Oh yeah, within a day. If it's more than a day, I wouldn't probably bother. Some people go 3 days.
But there's no evidence for an AC tap, right?
There's no evidence it does anything.
Why do you do it?
Makes sense. You're dropping the pressure.
But you can drop the pressure with Timolol and a
Massage.
little ocular massage pretty quickly.
Yeah, I don't like Timolol because of the circulation.
I know.
hate Timolol. There was a good. Do you guys know there was a good? There was a visual field study comparing brimonidine to Timolol, which nobody talks about. But the Timolol patients didn't do that well. Brimonidine was superior, even though it doesn't lower the pressure as much
I don't use Timolol
Yeah, I don't
on
like
my
Timolol
low pressure
for-
glaucoma patients.
for glaucoma. But
That's a problem sometimes.
yeah, it works. It lowers the pressure, but I don't think it helps the patient as much as
Right.
as the other drugs.
Well,
But
I mean, it makes sense. There ought to be evidence for it, you know?
yeah. Oh, to a tap? It's hard to do the study. A lot of stuff isn't studied. Medicine's like that. Things are gray. And the other thing is the risk of an AC tap is probably it's probably like an intravitreal injection. It might even be a little lower because I use a mid speculum. It's probably 1 in 5,000 risk of infection, in a blind eye. But it's true. I can't say that I can't say that helps. So you can reduce IOP with ocular massager drops. You can do an AC tap, Carbogen. Did you guys ever have Carbogen in the office? And I think in the old days people used to. And then ophthalmic artery TPA. Oh, and then some people are doing a YAG embolysis, which is kind of interesting and probably not helpful. And these people, I think, do need to be urgently referred to their medical doctor or the ER for a stroke workup. I don't think for the eye. I don't think it's to help the eye, but it's to look for stroke and for causes of stroke. And then 18% of the cases, which is a lot, you wouldn't think that, get iris neovascularization. So these people got to be followed sort of like vein occlusion patients. Although I don't think necessarily as long. I think probably 2 or 3 months is adequate. But there's no literature for that I know of. And then the last one's ophthalmic artery occlusion, which I couldn't find a case of. I had one of these when I first started practice, but I haven't seen one since I've been keeping my images. So it's very rare, LP or NLP vision, no cherry red spot, and it's an internal carotid dissection. Somehow you're blocking the ophthalmic artery. Mucormycosis, embolization, or these weird cosmetic things. You'll see cases now shown in meetings where the cosmetic fillers will cause ophthalmic artery occlusion. So lastly, I want to go over the preferred practice guidelines, because this is sort of where, I don't know that these are legally important, but they're medically important. The AAO has preferred practice guidelines they come out with. They're important because it's a panel of experts, it's based on data, and there's a 2016 one for retinal artery occlusion. So what they say in that is over 50, you should, when people write about retinal artery occlusion, they don't differentiate central and branch, which I don't like that. I think there's different, but this is just what there is. This is what the practice pattern is. So age over 50, you're supposed to check them for GCA, vascular occlusive disease. If you're young, you get a hypercoagulable workup. If they're old, you get an embolic workup. And then in an acute ophthalmic occlusion, ophthalmic artery or CRAO, you're supposed to do prompt and immediate referral for stroke centers. And there's no proven eye therapy, and you monitor for neovascularization. So those are the 5 things. So if you're going to remember anything about artery occlusions, that's what you need to know. If I were to modify this, I would probably go easy on the giant cell arteritis in people under 80, honestly. Giant cell arteritis in people, it's just super uncommon in younger patients. But
You said under 80?
yeah, you don't see it really. Your typical giant cell arteritis patient in my practice is sort of a sickly looking 90-year-old patient with something.
Oh, we've all had a few.
Yeah, they're younger, but not down to 50.
I've had one that biopsy proven that had a low set rate.
Yeah, I had that. Well, that might be the same, that orthopedic surgeon.
No, this is a
There's
lady
another
from
guy.
years
This
ago.
guy I saw, he's an orthopedic surgeon. When I wanted to get a sed rate on him, he started hitting himself in the head saying, "I don't have pain." They're so dramatic. And then he had a very positive biopsy.
It's probably from all the innings.
Yeah. So, all right, so here's some questions, just because it wrap it up. This is good, we're under time. So, which is not associated with Cottonwool spots? Hypertension, HIV, retinopathy, glaucoma, radiation retinopathy. These are not that hard. Just call it out. Glaucoma, good. Branch retinal artery occlusion is most commonly caused by which embolus? Cholesterol, platelet, calcific, or myxomatous? Cholesterol. Good. And then branch retinal artery occlusion. Okay, how many eyes have a ciliary retinal artery roughly? 5, 10, 25, or 50? 25. Yeah, about 25. They'll give you those where it's close. Ciliary retinal artery occlusion is commonly seen with detachment, central vein, central artery, or anemia. CRVO, yeah. Which is a little tricky because you would think CRVO, but actually CRVO you don't really see them. You see them in CRVO. And then Within 24 hours, a history of TIA, what should you do with them? Send them to primary care, send them to the ER, send them for an ultrasound, or start them on aspirin. Yeah, ER. Which, ophthalmic artery occlusion, ipsilateral Horner syndrome.
Dissection.
Yeah, dissection. Good. Okay, that's all. Good job.
You know,